All right, so I think we're ready then to begin the meeting on September 16th, 2020 at 5:04. All our board members are in attendance, as well as Mark Taylor, Tim Myers, and Kristen Kennedy. Before we begin, in keeping with the ongoing emergency order from Governor Charlie Baker to limit gatherings and maximize social distancing, and under legislation passed to address remote board meetings during the emergency declaration, this meeting will be conducted over Zoom. Attendance by board commission members will be remote, and remote attendance shall count towards quorum. The meeting will be broadcast live and recorded on ECAT. To join a remote meeting using your computer, click the URL at the top of the meeting agenda, or copy it and paste it into your browser. To join a remote meeting using your phone, call the number provided underneath the URL. You will be needing the meeting ID to join by phone only. Okay, so I think it's just us that's on, correct? Is there somebody other than us? Nope. So the first order of business is to approve the minutes from August 10th, 2020. Does anybody want to make a motion?
I make a motion to approve the minutes from the Board of Health meeting dated August 10th, 2020.
Second.
All those in favor?
Zayas, yes.
Mills, yes.
LeBlanc, yes. Okay, now we're moving on to variances, and it looks like 9 Crystal Lane, there's a variance to allow the wall of a swimming pool to be located less than 20 feet from a leaching facility. Green cards have been received.
Okay, I did see Frank Rivlin, who's the one that submitted the plan, and it's stamped by Walter Hermano for this on the list, but I don't know if we lost him or
No,
not.
I'm promoting him to panelist in a moment.
Do I have
Okay.
to introduce him, Kristen, or what?
You can recognize him.
Okay. So what we have here is 9 Crystal Lane, the variance to allow a wall of a swimming pool to be located less than 20 feet from a leaching facility. Under Title V, anything that goes subgrade, a cellar, a crawl space, a swimming pool has to be 20 feet from a leaching field. If the pool was there first and then they went to put the leaching field in second, this could be done as an LUA, but seeing the pool is being put in after the fact, it needs to be a variance and approval by the board. Butter notifications were given, and we do have the green cards in the folder. And the only questions I had for Frank is that he didn't show the actual distance from the field to the pool. It just says less than 20. And that's one of the questions I had. And also he shows concrete going over the septic tank, which we can't have. Aside from that, I didn't have an issue with it. Frank, do you want to speak to that?
Yes, I have uploaded a plan to Permit Eyes that shows the dimension of the existing leaching facility to the swimming pool. It is 14.6 feet. That was uploaded a few days ago. And
Okay.
we certainly would have no problems whatsoever in removing that portion of the deck that encroaches over the existing septic tank and keeping the concrete deck off of and away from the tank.
Okay. Board members, do you have any questions?
Nope.
I guess my only question is this, you don't feel there's any risk of, any safety risk with health with
No.
this?
And part of this will be a 40 mil poly liner that will go between the pool and the leaching facility field to protect from the leaching field from leachating into the pool. And that will be installed by a licensed septic installer, not the pool vendor. And we will inspect that. So that gives you your level of security there.
I'm sorry for the background noise.
So
Would
the potential risk is the septic leaking into the pool. That's what
Well,
the 20 feet is for,
Yeah.
essentially.
Yeah. And the same thing with cellar walls but we've actually put septic systems down to like 10 feet against the cellar wall just because there was no other place for the septic field to go. And in the use of a poly mill liner. So in other words, the liquid would hit the liner and then it has to go down below the bottom of the pool or the bottom of the cellar floor. So that's what the poly mill, it's a barrier to stop it from leachating sideways on the vertical.
Okay.
The horizontal, I'm sorry.
Okay, I have no more questions. Does anybody have any more questions or want to make a motion?
I'll make a motion to approve the variance for 9 Crystal Lane, variance to allow the wall of a swimming pool to be located less than 20 feet from a leaching facility, and green cards have been issued.
Do we
Second
want
the
to
motion.
say 14.6 or can we leave it at less than 20 feet?
Why don't we say the actual footage?
I'm sorry, Aria.
Okay, I make a motion to approve the variance for 9 Crystal Lane, variance to allow the wall of the swimming pool to be located at 14.6 feet from a leaching facility.
Second.
All those in favor?
Zias, yes.
Mills, yes.
LeBlanc, yes. Okay, thank you, Mr. Robelon.
Right.
Thank you very much.
Thank you. So next would be for Pond Road, a variance to have less cover over the field.
Okay, so I received a email yesterday afternoon from the homeowner, and he's decided not to seek a variance. He's just going to have the contractor come back, add the appropriate cover over the field and replant his lawn. His lawn had died this summer anyways, so he's like, I think it'd just be easy to go this route because he is having a hard time having his engineer come through and fulfill for the actual variance process. So he said, he's not going to do it. So we can remove this item from the agenda, and they're going to actually get the proper cover over the field and submit an as-built showing that.
Okay, so we don't have to make a motion to remove it. We just move on.
I would make a motion to remove it from the agenda.
Okay,
I make a motion to remove the agenda for a variance for 4 New Pond Road, a variance to have less cover over the field.
Second the motion.
all those in favor?
Zias, yes.
Mills, yes.
LeBlanc, yes. Okay, now we're going to move into action discussion. Novel coronavirus or COVID-19 update.
So I'm sure you all have been noticing that there've been slight upticks in the numbers in the weekly report that's coming out that's reflective of 2 weeks prior, Sunday to Saturday, of that actual reporting. Last week we did dip back down into green with a 3.9. I have been tracking it myself. Some of the methodology for calculating that number doesn't quite come out perfect, but I am very confident that we will be green again this week and that we will see that our rate is even lower, which is really, really reassuring and really good to see. That said, we are embarking on the fall. Tomorrow is the first day of school for the Easton Public Schools. We have worked very hard to put together a comprehensive document that can be edited, added to. If there are things we have missed that need to be addressed, we can easily update it. That went out to families a couple of hours ago, I believe, and hopefully will provide them with a guidance as to where we are and where we hope things will head as we move through the fall. It contains a glossary so that we are all using the same terms. It contains different response scenarios, and it is, I think, pretty comprehensive. It's got a bunch of resources in the back of them. I do realize I have to coordinate with the superintendent. Some of those links aren't working the way that they should right now, but it, I welcome any feedback as people have a chance to look at it. If people have questions or suggestions, They can email me directly at kkennedy@easton.ma.us, or they can email the entire staff using Board of Health, no spaces, at easton.ma.us. We are working on, we expect that we're going to probably have to tweak some reporting scenarios. The CTC has ramped back up again. They have actually expanded the purview of what they're doing, which is they are now taking on managing contacts for us that they previously were not taking on. We're gonna go slow and steady with that piece because we have some feedback and have noticed some cases where they have attempted to get in touch with people and advise them of what steps they should be taking as contacts of COVID positives, which is to maintain the 14-day quarantine. And they have not been able to either speak to the person, or people have actually flat out said, yeah, I'm not doing that, and hung up the phone. So we may be keeping some of that a little bit closer to our follow-up till we get some reassurances and make sure that people out there understand that the best way to stop the spread is to abide by these simple things: wearing a mask, social distancing, and taking seriously when we do contact people and tell them that they need to go into quarantine because they've been in contact with a confirmed positive.
So would that be the public health nurse, Christina, or?
As far as who would be following up and communicating with them?
Yeah, like for the people in the, if it's not going to CTC, I thought I heard you say that you were gonna, until you knew it was working, you were gonna hang on to some of the cases.
Yes.
I might have misunderstood.
Nope, Christina has been actively monitoring. That's how we know that some of these people are hanging up on the
Okay.
CTC people, because they enter notes, they check it off as being lost to follow up. So we've had discussions that we're going to be keeping a very close eye on that, especially since, we have the kids going back to school, and we want to make sure that if there are any contacts identified, that we're here as the first line and the first resource. So we're going to be following some of those a little bit closer till we make sure we've got a system down and that CTC has a system down. And we have the ability to adjust that way as needed.
I have a couple of questions, Kristen. I apologize if they're redundant, but we're just getting this playbook a couple hours before from Dr. Cabral before our meeting tonight. I really don't feel, I haven't had a chance to look at it. So I'm just kind of shooting from the hip. I apologize if the answers are in this playbook. I don't know about the other board members. I've had quite a few calls over the past 2 weeks asking if I knew anything about the school reopenings, this, that, and the other thing. Unfortunately, I was not able to answer many of the questions accurately. One of the questions that seems to be coming up repeatedly is, how are the desks sanitized between classes from kids?
So there is a set of guidances that have been put out by DESE that were worked on, collaborated with, and approved, is the best word I can come up with the Department of Public Health. They have looked at current science. They have looked at everything that they have been able to look at, and they have come out with the guidance that the desks need to be cleaned between users, cleaned after there's eating at them or things like that going on, cleaned in between if we have classes changing. And there's a lot of science that goes along with that position, that the cleaning is sufficient and that the desks would be sanitized I'm sorry, disinfected. I have the glossary in that document for a reason, and I
Yep.
need to check myself as well. That the desks will be disinfected at least daily, is what Desi said. Now, my understanding is that the schools may be doing above and beyond that, as they are taking a tact on a lot of these things of trying to do even above the standards that Desi has set.
So for clarification, I think for a lot of people, who is DESE? What does that stand for?
So DESE is the Department of Secondary and Elementary Education,
Okay,
and that's in the list of acronyms in the book.
okay. And what exactly is the sanitation process in between classes? Do we have that nailed down yet?
So the process that DESE has recommended is that the desks get cleaned. If you're talking about at the level, the middle school and high school where kids are changing
Uh-huh.
rooms. So the process is that DESE has recommended is that those desks get cleaned as in between users. So that will be done with soap and water. The actual who's doing what, that's not, as far as I understand it, they've worked out different procedures for different classrooms, for different age groups. So the cleaning is what needs to happen as that is going on throughout the day. At the end of the day, at least daily, the desks need to be disinfected.
Mm-hmm. So soap and water, and I'm sorry if I'm picturing like a bucket with somebody with soap and water. So
I believe they're going to use spray bottles and paper towels.
So there's, in every
Okay.
classroom, there's a spray bottle and they will provide paper towels. And the way it's been put out there is that the teachers will probably spray the desks and the kids will wipe them. Get rid of the paper towels and then use hand sanitizer or wash their own hands before leaving the classroom. There is disinfectant in a bottle available. And it's to be used. It's not as part of the internal procedure that will be done between kids. That's the way the procedure has been put forth, but it is available for any teacher or student that wants to use it.
Okay, and if that satisfies the state and DESE, I guess that's satisfactory. Now, in the event, and this is me putting my paramedic hat on, in the event that a child were to come to a school nurse and had some symptoms, whether they developed throughout the day or what have you, what do we have in place to isolate that that child? And what would the procedure be moving forward with that? As far as, I mean, unfortunately, I'm only familiar. I mean, the school nurses' offices are limited, and they're not really, from bed to bed, not very isolating. So how does that work? I had 3 questions about that.
Yep, so the reopening standards that were put out by the Department of Secondary and Elementary Education called for the establishment of a COVID waiting room in each of the schools that's separate from the nurse's office. There has been a lot of work done throughout the summer to set one of those up in each and every school. I have not seen them. Lynn, I believe you've seen at least one, if not more than one. There are logs that will be kept of who's in that room in the event that somebody exits that room and subsequently tests positive and had to overlap with somebody. They'll be supervised. They'll be separated from the general flow through the nurse's office.
So
Lynn may have more to add from her personal knowledge.
so those rooms, I'm assuming they don't fall under like health services inspections or whatever, but I'm assuming they're ready to go.
So they're called medical waiting areas now, or waiting rooms. And I think that I did not check today because I was so inundated with medication drop off, but I'm not sure if the DPW put up some barriers between cots that they were going to. But I can tell you, each school had different obstacles. At the high school, we were a little bit luckier. We have a teacher's classroom. The engineer came in and checked the ventilation. We have a whole classroom with 3 cots and a desk for the kids. So we can actually spread them out, 4 kids out in the room at once. I know other schools, it's been a little more challenging for the older schools. And what happens is when a kid comes to the health office, they're going to be triaged. We have 6 feet distances marked outside outside our office where they'll wait to be checked. If they are for instance, a diabetic or a daily medication, they can come right in. So they come in and they have a designated spot only for them that's plexiglassed and partitioned off to keep them safe. The other kids will get triaged. If they meet the criteria for potential COVID, they will be given a surgical mask. And one of the 2 nurses there, and that's why we needed 2 nurses, because we couldn't just close the office and walk the kid down to the medical waiting room, because I could have diabetics in there. You know what I mean? Or kids lying down on the cots with other
Well,
things.
that's my concern. Yeah.
So no, so they won't enter the classroom, Chris. We're supposed to have 2 nurses at all times so that won't happen. And we walk them right into the medical isolation room. And from there, we should have a phone, I know, in that room to start making calls to parents and stuff. Okay.
That kind of leads me to my next question. So let's just say, and I hope it obviously never happens, but that we do end up with a positive COVID student. Who is responsible for the contact tracing at that point, and how will that happen?
Kristen?
So the contact tracing will go the way it would with any other positive case in the town. We would be taking the lead. Our public health nurse would be taking the lead, but we have added a layer with the schools where there will be an intern in place who will be able to act as a liaison to the Board of Health office. And we'll be able to get a jump start on such things as if it was a lower grade, the seating chart, what students would be within that 6-foot radius around the student that tested positive. Were they then checking attendance records and making sure that the kids were actually there before we went any further? They'll be finding out whether or not the child rode the bus, what the arrangements were for that, and kind of tailoring that right into our then contact tracing done by our public health nurse. And notification would go out to those families that are affected by a positive case within the schools, and they will be instructed on quarantining and how to take their child and quarantine their child at home for 14 days.
And I apologize if those questions could be answered by reading that packet.
No, this is great information to get out there. These are the top questions that everybody has.
Okay, I feel terrible that I
Don't
haven't
feel
had
terrible, Chris. These are
No, this is
No,
great.
I just, you know what, we
these are the
should have had,
questions everyone's thinking.
I gotta be honest with you, I feel like we should have had better access to some of this prior to this meeting, and I'm a little frustrated with it, to be perfectly frank. Because, you know, as a parent, a high schooler, I get asked quite often. I mean, I'm in town all the time, and I'm also a paramedic, and I get asked quite often these questions. Getting this, and I'm sure it's through no fault of anyone here, but getting this kind of information the day before school starts, whether it's remote or not, is I find it, I'm a little frustrated, to be perfectly honest with you. So I'm just trying to skim through it. So please don't think I'm not paying attention. But, you know,
No
I
one
have,
thinks.
have concerns. I also have concerns that we don't look as competent because we don't have this stuff prior to. So
I-
just go right by me for now.
No. So I do wanna say the nurses have volunteered and worked all summer. So one good thing is that some of this information has been leached out through the weekly newsletters from the school system and like checklists and certain things. Jesse just came out on Friday, finally, with COVID scenarios and what to do. I'm not going to say any more on that.
Yeah, a lot of the information has been slow coming and slow to be confirmed from above us. We've been working on these documents and this messaging since the very beginning. How a contact is treated is the same way it's been treated since March. Anybody identified to have been within 6 feet for a period of more than 15 minutes is identified as a contact and then followed up on. So a lot of our families out there have already had interactions related to positive cases with our office. What we're doing will be the same process that we've been following all along. We just now have hopefully added a few layers with an intern liaison and some, additional steps and checks and balances amongst ourselves that will hopefully make this process go smoothly for families.
When will we be
As
up-
Lynn said, DESE has not, and DPH have not been giving us information that we can count on, not changing. Some of the things that came out on Friday were revisions from earlier in the week. The answers keep changing on this, and that's why hopefully this document will stay a live document and we'll be able to update it as changes, as we're made aware of changes, as we're also made aware of questions. If parents have questions that are not addressed in this document and they'd like to see them included, again, if they address their comments or questions to either my email, kkennedy@easton.ma.us, or the general office one, Board of Health, no spaces, @easton.ma.us. Much like the state gets the same question from 10 of us as health agents, if we're getting the same question from 10 parents, then we obviously haven't presented it in a clear enough way in this document, and we'll go back and look for a clearer way to convey that information.
Thank you. I'm wondering, given schools starting up and, there's a potential for an uptick or a surge, I don't know what the right word is, would it be something that might work if we met more often instead of once a month? How would the board feel about maybe doing twice a month? Is that something we want to consider? And can we consider it if it's not on the agenda?
I think it's your COVID response. I think setting your meeting schedule is appropriate and responding to it, much like when we first started dealing with COVID in March, April, and May. We added additional meetings to deal with topics that came up. We had the meeting for our own mask piece. We had our meeting for our own reporting piece. If this is something that the board would like to consider for the next few weeks, even just meeting even once a week if you want. And it's this COVID being the only COVID, and maybe before we jump ahead, maybe Arbovirus, keeping that on there as well. Maybe those two subjects could be looked at once a week. I will say trying to get a meeting room for Mondays may be difficult, but we can pick a night. We can try for Mondays again if that's more convenient for everybody, or we can stick with midweek so we know what's going on. My fear is if we were to set a meeting date for next Monday, we wouldn't really have any data. I think if we were to meet Wednesday or Thursday of next week, we will definitely have identified any immediate bugs in the system. We will have some feedback. I don't think we would see, given the incubation period is 2 weeks, would hope that we wouldn't see any real cases popping up in the next week. If we do, they may not be attributable to the school environment, which is going to be a very important piece to consider as we look at our cases coming forward and we do our contact tracing, that we are looking back and making sure that positive cases, while they may be a school-aged child, may not be related to an exposure and may not create additional exposures in the classroom setting. As an example of that, if we have a student in cohort A who goes to school on Monday and Tuesday, Wednesday, because it's a remote day, they go off and spend the day with Uncle Joey because he's a fun uncle and, you know, he's going to help get things done. And then on Thursday and Friday, they're at home learning remote, or they are involved in one of the pod type settings that are being established for some of our younger kids to supplement daycare for parents. And then he gets sick on Saturday or Sunday. He gets a COVID test on Monday and stays home from school. His COVID test comes back positive. We're going to look at his symptom onset as being Saturday or Sunday. Let's pick Saturday. He got sick on Saturday. We're going to contact trace and do a 48-hour look back. That 48-hour look back takes us for Friday and Thursday. He was not in school Friday or Thursday. That case, yes, it's an Easton student, is not going to affect the kids that he was around.
Okay.
So this is going to be very detailed as we look at each and every one of these cases. If you guys want to meet next week, that's fine. If you want to give it 2 weeks from today or 2 weeks from and try for the 28th, we can see if a meeting room's available.
You know, this is, and I hope this doesn't come out the wrong way. And I'm not upset, but I almost feel like I'm in the dark a little bit. And I feel like I should not be getting or hearing about like some procedural cleaning, that kind of stuff, or everything. I watch the school committee meetings, and while I may be one of few that do, Dr. Cabral refers to you and the Board of Health quite a bit, and the people that do watch them, I'll get phone calls during the meeting. Well, did you hear about this? Did you hear about this? And my answer is, well, no, I'm trying to be honest. And, I always say no, but I can find out, but I shouldn't. I don't know. I feel like we should be in the loop a little bit more than we are, if we're a valued team. And right now, I'm taken very back with this packet before our meeting, and we were just meeting once a month. So, I mean, me personally, yes, I would like to meet a little bit more often if we're going to deal with this, because I think Easton's really on top of this. The Board of Health is great, and we're very ahead of it. And if this comes back with another surge, which everyone's planning on it is, we're going to be that much ahead of the game. But I unfortunately, and I apologize, but I feel a little bit in the dark. And it's now the day before the first day of school. Granted, the older kids are not going tomorrow, thankfully.
So Aria, I don't know if you want to say something or you want me to say something first, or.
I mean, I was just thinking, Kristen had sent us a preliminary packet of all of this information over a week ago. So, Chris,
it was a PowerPoint, and I repeatedly try to open it up, and it's blank, blank, blank for me. So the first thing,
no problem.
And I just assumed because
that wasn't complete, though. I think that was.
Yeah, I just assumed because it was draft that, okay, it's fluid. And again, I'm not blaming anyone. This is us that we need to. I just want to be able to answer questions when I get them. That's all.
So I want to say that I would like to meet more often, if the board agrees. I would like to meet at least every other week. I hear what you're saying, Chris, and I feel like being on the Board of Health during a pandemic, that perhaps we need to be more in the know and we should be part of the conversation. I do agree with you. If that's what you're saying, that I agree with that. If coming every other week helps to that end, that might be something we want to consider. I know Kristen Kennedy works incredibly hard, and thank God for that, but we can be helpful. We're lucky to have people that have medical experience, and I feel like we can really, really weigh in and contribute quite a bit.
Are we allowed to make a motion to
I have
change
no idea.
to
You
bi-weekly?
don't need to make a motion. We can just go ahead and do we want to try for Monday, the 28th, or do we want to try for 2 weeks from today?
If Mondays don't work, I can do Wednesdays. I don't have much going on these days. What about you guys?
Wednesday's perfect.
Whatever works for everyone.
So what are we proposing? Which day? I can do the 28th, 29th, 30th, 31st. I don't have anything going on.
Yeah, I know, right? Whatever works.
Yeah.
So do we want to say the 30th? Is the 30th the Wednesday?
Yes.
Yes.
Does that work for you guys? Everyone? 5 o'clock?
I believe so. I will make sure that there is a room available.
If not, just let us know. I'll put it in my phone.
And Chris, if you ever have technical difficulties again, please let me know and we'll switch it to a different format.
I just assumed because it was draft that that's just all I was getting. I didn't even think I didn't think I was having difficulties.
No, I mean, it was the initial mission statement for this book. It was.
I just tried on my computer, my iPad, and my phone, and I got all the pictures, but there were no documentation, no words or anything.
Okay, well, as I said, if you have difficulty opening anything, please reach out to me and individually, and I'll switch it to a different format and try to get it to you in a way that you can see it.
Yeah, like I said,
Additionally, as I get emails of information that's coming through from DESE and DPH and the early education people that are ramping up for a whole different kind of daycares to basically, so there's a licensing, daycares need to be, for school-age children, there's a licensing little glitch with the daycare, and camps can't operate beyond the end of September statutorily. So there is a void in there for parents that have children that are school-aged to fill for the days that they're doing the hybrid. And we're all hearing a lot about these pods being set up and smaller groups being set up. And so there's a whole new licensing procedure that's been approved and laid out there that, of course, the state thinks we can take the lead on. So there's documents that are coming through 2 or 3 times a week relative to that scenario as well, for where some of these kids will be spending their Wednesday, Thursdays, I mean, their Thursday, Fridays, or their Monday, Tuesdays if they're not in the classroom. I will try to make an effort to start picking some of that may be relevant or of interest and flooding your inboxes with it.
That sounds great. Thank you so much. So do we think we are done with the COVID update, and we're ready to move on, or what do you think?
I mean, it's fine with me. We've had nothing going on with the with our group homes, knock wood. We've had nothing going on with our assisted living. Stonehill has been doing a phenomenal job. They are testing upwards of 800 students and staff 4 days a week. Last week, they moved to testing their athletes and some of their other participants in what are considered higher risk activities that involve singing and things like that. They're now being tested twice a week. And they are handling, spent a lot of time this summer, put a lot of pressure on the state to create a method that would allow for a really cohesive and aggressive approach to contact tracing on the college campuses, where Stonehill is willing to do the initial contact tracing and isolating of all of their cases, but then wanting to be able to turn it over to the state. One of the things that came out of that is now Stonehill has access to, you've heard me talk about Maven, the electronic system that we record all of our reportable diseases in. They actually have set up a separate unit at the contact tracing piece. Stonehill has Maven access. They have basically they're all working together and handling all of their follow-up, although wonderfully there isn't a lot for them to do right now, which is very good news.
It is good news.
I,
Go ahead, Bruce.
So I have a Stonehill student, so this is probably speaking as a parent, but the testing that I was wondering this the other day, the testing that they're doing at Stonehill, is it the quick test? And a lot of people would like to know how accurate the quick test is versus the test that takes several days to get back.
So there are two different tests that are available. And they are, one is a PCR test. And the important thing about the PCR test is that it has in its process, not to just to really cut to the chase, it has a process where there's an opportunity for the virus to replicate and the RNA piece to replicate. So the PCR, which is the preferred and is the gold standard, that detects genetic material from the virus in a lab, and the PCR stands for polymerase chain reaction. The sample is same as everything, taken from the nasal, throat, nasal pharynx, or saliva. It can be a rapid test, but it more likely is one that is sent out and takes a couple of days in a lab. If it's sent to the state lab here in Massachusetts, it typically is only taking 24 to 48 hours. It also is, that is the test that Stonehill is using. Stonehill is contacted with the Broad Institute, which is Harvard and MIT. They have, the PCR, they have a courier coming, I believe, twice a day now because of the number of samples that they're getting, and they're getting their turnarounds. Initially, they were getting 24 hours. I think they might be up to around 30 hours on their turnaround time, which is fantastic considering a lot of people going to walk-in clinics and places like that are having to wait 4 and 5 days because their tests are going out to the national commercial labs. The newer test that's often thought of as more of the rapid test is an antigen test. And that one detects the proteins that are part of the virus. There's no process to amplify or increase the number. You can only detect what's there at the time. It is not as sensitive as the PCR. And because it is less sensitive, you don't have that amplification, it will miss cases. So you will get a false negative. It also is less specific in what it's looking for. So you get a good number of false positives. At this time, the Department of Public Health is recommending if you do get that rapid test, you still get a PCR test to confirm the test results. And the analogy I use on this one that I think hammers at home for a lot of parents is we've all been at the pediatricians with our kid with the fever, with the big white spots on the back of their throat. And we all know, we all feel in our gut, it's strep. And the doc comes in, does a quick swab, goes back out to the lab and does the rapid strep test and comes back and says, nope, negative for strep. And 2 or 3 days later, we've gotten the phone call saying, hey, we sent that out and guess what? It was positive. So it's a very similar type of process for the COVID rapid test. It is, the antigen test is not as accurate. It's not as specific. It also has not gone through the normal, it's been licensed under an emergency use. So there is no standard out there anywhere that says it has to be at least 50% correct, or 60 or 70 or 80%. So it is a tool, I suppose, but it is not the recommended way to go about doing it. The recommended way is the PCR. You have to be patient and wait for those test results. But
That's what
to answer your question, that is what Stonehill is doing. They are doing a PCR.
Oh, okay.
So there are no, this just came to me. There are no requirements from our school system at this time for which test needs to be done when we send a student or staff member to the primary care physician to get evaluated. Is that correct?
I would expect that physicians out there, that messaging out there would reflect that the PCR is the test that is going to give us the most accurate response. And to back that up, the governor's travel order is requiring it be a PCR test. So in my mind, my expectation would be that, and since all prescribers and all physicians have been told that if they do this rapid test, it should be backed up with a PCR, and especially if somebody is symptomatic, they should be waiting for that PCR test to come back. That would be what we would be hoping and anticipating and encouraging people to avail themselves of. And again, it's becoming educated because, you don't know until you ask. But that rapid one that you are waiting in the parking lot and they're coming back out and giving you, that's not the PCR. That in all likelihood is that antigen test, and it is going to yield a certain number of false positives and a certain number of false negatives.
Okay, so we are kind of expecting the healthcare providers to know what they need to do. So in your conversations and your collaboration with Dr. Cabral, if we have a student who's asymptomatic, but it was a close contact, so went and had the quick test done, that's acceptable. We're not splitting hairs and asking which test. Is that correct?
The scenario you just referred to is the contact being tested.
Mm-hmm.
And they can get tested, they cannot get tested. They cannot return to school till they've exhausted their 14-day quarantine. Testing while in quarantine does not get you out of quarantine. It's a tool, and it's a tool to be used potentially in your household, that if you tested the child, the student, 4 or 5 days in, either PCR or antigen, and the child came back positive, you could take certain steps within your house to be much more conscious of how you interact with that individual, using different towels, making sure you're using different towels, making sure their laundry is done separately, making sure that they're keeping 6 feet apart and wearing their mask when they can't, dedicating a bathroom to them if at all possible. These are all steps that should be being taken, but with knowing the child was positive makes people take it a lot more seriously. It also, once the child tests positive, then we can adjust the dates for how long they're either in quarantine or isolation as well.
So, thank you. So the kid that has mild symptoms, has the rapid test, it comes back, they're waiting for it to come back. Because they're waiting for the test, they have to stay out of school. And if it comes back negative and they're feeling better, they come back to school, just to clarify, correct?
I believe that is the protocol that DESI and DPH have recommended. That's our standard, throughout since March. If somebody was symptomatic, went and had a test, tested negative, felt better, they were allowed to enter back into society if they have no known exposure.
Thank you. And I've been told, I've not seen it yet, that parents are going to their pediatricians and they're getting the antigen test instead of having the PCR or the rapid. What are your thoughts on that?
The antigen or the antibody?
Antibody, I'm sorry.
That's okay. I
I
figured
always,
that's where that's where you were going. So the antibody, again, COVID is new. It's new to all of us. How it behaves, what it elicits for a response in our bodies, we don't know a lot about. We know that for the majority of us, when we've had chicken pox, our body not only fights off using our resources, fights off the chicken pox virus, and then keeps backup soldiers called antibodies in place in case it were ever to come along again. And those antibodies step up as little soldiers and fend off the chickenpox vaccine. We've determined that for those of us that had a legitimate case of the chickenpox as kids, that confers from the majority of us lifelong immunity. We don't know enough about COVID yet to have any of those answers. And we're going back and forth between if somebody goes and has a COVID test. So just, I'm going to say months ago, when the antigen test first came out and people started getting tested for antigens, if we received a positive antigen test, DPH was treating it as a brand new infection, and we were placing people in quarantine and saying, well, you must have it right now, because we didn't know enough. Whereas with some other, again, historic illnesses, mono, where we can look at the different levels and say it's a past infection, it's an active infection, we don't know enough about COVID. So when they were initially doing the antibody tests, if the person had no symptoms, we were placing them under quarantine. They quickly realized that wasn't probably necessary, because by the time we were detecting antigens, they probably were outside of the window, or they were self-reporting that they had the antibody test because they had been sick back in February and wanted to know if they had really had it. So the antibody test doesn't really tell you a lot, other than if it's positive that there has been an infection. There's no way of knowing how long ago it was. There's no way of knowing currently how many of those antibodies, or a titer number, that make you immune, or how long that immunity lasts. So basically, if you have a positive antibody test now, and I'd have to go back, I don't have it at my fingertips, I know the maximum amount of time that you're considered to have an implied immunity is 6 months. I could be going back, it might be 6 weeks. There's a 6 month and a 6 week number for after you test positive, you don't test again for a period of time. So again, it's just, and it changes. I could look the answer up right now and say, yep, this is the answer I have in my hands right now. And that answer could change tomorrow. We don't know enough about COVID. The bottom line, the PCR test is good. It tells us if somebody is positive and has COVID-19, and should be the one thing that people are hanging their hats on.
and in your collaboration with Dr. Cabral, if a doctor says they're cleared to come back to school on a certain date and it meets the contact traces criteria, we're not bringing up whether it's rapid or PCR. We're not looking into that.
I don't know what type of documentation the doctors will be providing. Some of this we're going to have to hash out on a case-by-case basis. The protocols are pretty clear that if a child goes home asymptomatic and sees their doctor, is tested, and has a negative test, and their condition improves and they're fever-free for 24 hours, that they can return to school.
Okay.
We'll have to do a little more digging and actually possibly go back to DESE and to the Department of Public Health and see if they have any intention or any opinion on defining that the same way that they've defined which test is acceptable for travelers returning or entering Massachusetts.
Okay, thank you. I think, I mean, everyone looks like they're falling asleep, but I think that clears up a lot of questions, at least that I had. So are we ready to move on to the Arbovirus, Tick-Borne, and Mosquito-Borne illnesses? Mark,
Yes. You guys ready?
I think we're ready.
Or-
Ready?
Okay. So first off, want to let you and people know that as of September 11th, last Friday, the ground spraying for adult larvicide mosquitoes has been discontinued for the year. The mosquito count is naturally going down at this time of year. So that's the first bit of information I want to let you and the people know. And then as of today, we did get our first West Nile virus positive pool, which is approximately 50 mosquitoes in a pool that's tested for West Nile virus. The type of mosquito is generally a bird biting mosquito, has been documented biting other mammals and stuff. So precautions still need to be taken long sleeves, bug spray, at least it's cool out now. So, and then avoiding dust and dawn activities if you can, for this. But so that's what we got going on with Arbovirus. We don't currently have, and our risk level is at low. The only better is that than is moderate. So no, I'm sorry. We're at low. Just leave it at that. And then it goes moderate, high, and critical. We still don't, knock on wood, don't have any EEE positives at this time. So that's the update for Arbovirus. If Kristen has anything she wanted to add to it.
Nope, just that we are, the threat for EEE is dropping for all of our Arborborne illnesses is dropping. Only 5% of identified cases historically occur after or into September. So thus, being at the tail end of the transmission season, we hopefully have dodged a bullet this year. West Nile can be active well into October because of the way that that particular mosquito that we had test positive, because of the way it overwinters, which is a little bit unique compared to some of the other mosquitoes. We do want everybody to be diligent and cautious and just practice good habits. In addition to their mask, they want to be putting their bug spray on whenever they're going to be outside and could be coming in contact with mosquitoes. But it's hopefully the mosquito season will come to an end soon, given the chilly nights that we're starting to have. Hopefully, maybe we'll have an early frost and we can close this chapter completely.
That'd be nice after last year. Anything, guys? Nope. Let's move on to the discussion regarding tobacco permit capping. I think we asked to keep that on the agenda.
We tabled it a few meetings ago.
Do we want to table it again this meeting?
Is there anything
Or any
pressing?
information?
Is there anything pressing going on with it right now, Kristen?
No, not really. We're not hearing a lot about it. You guys had just asked to kind of keep it on the agenda and see if it was anything that you were interested in. We can table it again for another few months. We have not, to my knowledge, and Tim, Mark, chime in, we have not had a brand new location. I know we've had, our permits don't transfer, so we've had new permit holders, but I do not believe that we've had a new permitted location in quite some time.
And we've had no applications selected this year.
And I think that's what we were like waiting to see if it was going to become an issue, correct?
Yeah, there does not seem to be an overwhelming desire to open up stores to sell the tobacco products that are allowed or others that would be in different environments.
I'd make a motion to table this to November, revisit it then.
Seconded.
All those in favor?
Zayas, yes.
Mills, yes.
LeBlanc. Yes. So, thank you for that information. And we'll table it till December. And let's move on to the Easton Housing Authority fee waiver request. I see it in the packet. Some information.
The Easton Housing Authority, they need a new septic system on Foundry Street. And they're just looking to have the fees waived for the repair of their septic system. Due to the size and the volume that it would be, normally it would be a permit fee of $900, but they are seeking to have that waived.
And we typically do this historically.
Say it again, Chris, I didn't hear.
We historically waive those fees.
We do?
I'm asking.
Oh, I'm like,
Tim,
They did pay for the perk test fee, but I believe the one that they had done at Parker Terrace, that was waived.
Okay. I'm fine with that. Make a motion to waive.
okay, I just have a
Oh,
quick
yeah,
question. Now, our agents, is this something that you do a lot of work with and you feel like waiving the fee is going to be a big deal, or for you guys, it's really something that?
Well, it's the same amount of work, whether we get $900 or not. You know,
Okay.
the last time, and we probably need to, when COVID finally slows down, is review the fee schedule. But anything that was considered a large system, over 2,000 gallons a day, or an IA system, would have to be a $900 fee. So there's a lot more work that goes into an innovative alternative system, IA system, than goes into a regular backyard system. And then also with over 2,000 gallons a day, you have things like mounding analysis and things you have to look into as well. So this is an innovative alternative system, and it's just over 2,000 gallons. So there's a little work to be done with it, more so than, say, replacing a 4-bedroom septic system in your backyard.
So if we deny this request, I mean, would that pose unsafe to the residents if that is the sort of stopping ground for them being able to proceed with the project?
Their septic system currently is in failure.
Is in failure.
It is.
Okay.
And this design that they're planning is 3 different leaching fields spread out throughout the property. So it does need to be repaired one way or the other.
So I feel like I'm hearing two different things, and maybe it's just me, that it is quite a bit more work, and that's why there's a different fee that's involved. And then no matter what, it's the same amount of work. So I'm trying to be sensitive to what our health department has to do to get this done. I'm sorry.
so it is past practice that we would waive fees for other town departments and buildings and things like that.
Yeah.
The housing authority is not a town entity. So this is a little bit different in that regard. But past history, Tim did investigate and we did waive fees in the past for the housing authority.
I guess my question is the $900 to the housing authority, is that going to prohibit, if we don't grant this, is that going to prohibit them from moving forward with the project?
I'm sure they'd pay the $900 if they had to. And that's the way I feel. Tim, speak up. You spoke with them more than I did.
Yes, I mean, the construction cost alone is going to be thousands, so tens of thousands.
And they don't have a choice, correct? The system's in failure?
That is true.
Is this cost prohibitive to your department?
It is, I mean, every time you waive one, it's a little bit, impactful. This is a larger system. This is just the review of it takes longer. The number of inspections is going to take longer. It's kind of torn because past practice, we have waived the fee for the housing authority. We're going to do what needs to be done to make sure things get done right, regardless of the flow of money in from our permitting fees. This is what we do. We're not going to not oversee the construction of a septic system that impacts 7 households and 7 vulnerable households at that.
I feel like if we have a fee schedule, it's there for a reason. If it was a hardship case, I really feel like we should consider waiving it. But what I'm not really understanding is this just because it's a lot of money and would rather not pay all that? Or is this like a hardship case where we should put aside what all our health agents are doing for work and waive it? Do you know what I'm saying? I'm just really not sure. I know that as long as I've been on the Board of the Health, we've been quick to waive because we don't want anyone to have to spend more money than they need. But we're a small office working really hard during a pandemic, and you guys work super duper hard. And I feel like I need I know it's our decision, but I kind of need your guidance on this. I do.
I mean, in the past, we've waived fees for nonprofits so that the permitting fee doesn't cut into their ability to raise funds. Other scenarios where we have waived fees, I believe, again, probably were charities, or we typically waive them between town departments because there's no sense in, the fire department paying us for a septic permit when it's the same pot of
Sure.
money.
Is this one of those cases in your opinion? Similar to one of those kind of scenarios?
I honestly don't know enough about the finances of the housing authority and their federal funding to really speak to whether $900 to support our inspectors and our processes would be impactful in the construction of Tim, help me out here. They're looking at how much for the system? Have they said have they thrown any numbers out?
No, we haven't received, all we received is the plans, but it is 3 different leaching fields. It's going to be a whole new driveway because that all has to get ripped up. Septic tanks, pumps, electrical.
So, I mean, it doesn't appear that $900 in permitting fees would be terribly impactful. I mean, the other option you could do is you could take it down to what we normally charge for a repair. Yes, it's a little bit more work. That's why we have, implemented for these larger systems a calculation based on the linear feet of sewer and the different pieces that are involved.
And what is that?
So the normal repair is 100, guys?
Yes.
Yes.
I mean, it's your fee schedule. You could reduce it by half. You can waive the whole thing. You can say, nope, we want it.
So I just, I urge everyone to just consider if we start changing things that have been historically one way, that we may have a lot to answer to down the road, because now the next person that comes in and says, well, you charge this one, you know, you're not charging, it almost can get discriminatory. And I've seen that happen actually in other situations. So if we're dead set on charging them, I mean, and believe me, I follow the town's finances, and I get it, and we need to bring in as much as we can. If we've historically not charged a group like a church group, or like Kristen said, a nonprofit, to go ahead and start doing it without valid reason, means we have to kind of start doing it for every one of those types of things.
This is not a nonprofit. This is a federal entity.
Right. So that being said, you know, I would be inclined to reduce it to half, but not where they've always, and I don't know why, you know, boards before us, they've never had to pay for it. But it's just, we have to be very careful about how and why we do that as a board moving forward.
I agree. We should probably make that, have that conversation. I agree. So, building on what you said, is the board thinking that reducing it to half is a good compromise?
That's what I would recommend.
Would you like to make them, does this have to be a
I
motion?
mean, if the other thing too is if you're uncomfortable tonight and you want us to check back with council, if you want us to look at what some other people that they're seeking or potentially are seeking permits from are doing as well, you can, since you're going to meet in a week and a half, you could, or 2 weeks, you could table it for 2 weeks. We can
Does that hold
not,
them- Does that
we
hold
can
them up?
not, we can make the decision to move ahead with the plan review. You know, given the current load, how long has the plan been in the office?
1 second, it's right behind me.
Yeah, we don't necessarily have to issue the permit. We can review the plan.
Yeah, typically we do not begin review without payment. We can go ahead and begin review and just not issue it until the board comes back with a decision on, we can put it on the agenda the 30th.
I mean,
It's
will we
been,
have,
we've had it almost a month.
would we have any more information in 2 weeks?
We could look into, you know, if there are other boards that have even a written guidance as to, or a you know, a philosophical guidance that they stick with on who they're granting for and not granting for. We can look at whether other departments have been asked to waive their fees for this particular entity, whether they've asked conservation or others to waive fees, and see what other departments have done. We could gather some more information for you.
Yeah, what you said, Kristen, I feel like how I feel like I want to be fair to everyone. I want to be fair to our Board of Health, and I want to be fair to the Housing Authority. But I just feel like if there is a possible way of moving forward, but getting more information before we make a decision, that would help me. What does the board feel?
I mean, honestly, I feel like, I feel like granting this waiver is not necessarily fair across the board to all other entities in town.
And-
That's just my,
No, and so to that end, like, would you recommend, what would your thoughts be on either making that decision today or waiting for more information? Do you feel like you even need more information?
I mean, I would be happy to make a motion now. I'm fine now. But it doesn't sound like that's the consensus.
Chris?
Like I said, doing something how we've done, you know, how we've done it in the past, if there's been good reason. And you know, like in the building department, I know that they waive certain permits. And like to Kristen's point, if the DPW pulls a permit to work on something in town, it's ridiculous for it to go back, into the same pot of money. That being said, shame on me. I did not realize, thank you, Kristen, for pointing it out, that the housing authority is a separate entity.
I didn't either.
So, and that, I would be willing to waive it or reduce it to half. That's me. I'm fine with doing either or we could collect more data. I do know, I mean, if they're hurting for a septic system and it's not great, I don't know if they're pumping weekly or something like that, because it's that bad, but it's frustrating when you're waiting for a permit. So I would not want to see that delayed if they've already, the stuff has been submitted already a month ago. So if there's a way we can move forward with that and deal with the finance after doing some further research in 2 weeks, I'm okay with that as well. But I Kristen makes a good point. It's not, I mean, it's the Easton Housing Authority, but it's not the town of Easton.
So from what I'm hearing from us as a board is that, and I respect what you said, Aria, is that it could be something that they could continue to move forward with, but we would work out the financial piece after Kristen or whomever does some more digging and maybe revisit it in 2 weeks. Is that okay with everyone? Do we have to make a motion or anything?
You can just make a motion to table the request and place it on the agenda for the 30th.
Would anybody like to make a motion to table it?
I make a motion to table the discussion of the fee waiving for the Easton Housing Authority for their permits for their septic to be rediscussed on Wednesday, September 30th.
And I did do a review and send a preliminary review on 9/2. So I have started the review process on it. Just want to let you know.
A second, Zayas' motion.
All those in favor?
Yes, yes.
Mills, yes.
LeBlanc, yes. All right, thank you. And then I have to find my agenda again. I have so many screens open. And then we're just doing some betterment applications. So the first one is for 470 Bay Road.
Yes, so currently the system's in failure. They're good standing with the town in terms of their taxes and other bills to the town. They put in an application. The perks test has been scheduled, so we don't know exactly how much it's going to cost. So they're seeking $30,000.
Okay, sounds pretty straightforward.
I make a motion to approve the betterment for 470 Bay Road.
Seconded.
All those in favor?
Yes, yes.
Mills, yes.
LeBlanc, yes. And then we have 880 Washington Street.
Yes, so same thing. They're pumping almost weekly. And so that perk test has been scheduled. Again, we don't know the design criteria because we haven't conducted the perk test, but it has been scheduled and we're getting out there as soon as possible. So they're asking for the 30,000 as well.
Okay,
I make a motion to approve for 880 Washington.
Seconded.
all those in favor?
Yes, yes.
Mills, yes.
LeBlanc, yes. And that concludes, I think, our meeting. I just want to thank all you guys for doing all you're doing during this pandemic. I know you're out straight.
Seconded.
Great. So we're gonna conclude the meeting of the Board of Health at 6:23 p.m.
Thank you.
Did you guys take a motion to adjourn? And
Do we?
Yeah,
Yeah.
yeah.
yeah,
Yeah, I make a motion to adjourn.
Oh my God, we're so rusty.
I make a motion to adjourn the Board of Health meeting at 6:23 p.m.
and
Second,
then by roll call.
All those in favor?
No, roll call.
We'll tell.
You have to do it by roll call.
Yes, yes.
Mills, yes.
LeBlanc, yes.
Thank you.
Thank you.
Have a good night.
Bye.
Night.